You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. To view the CE information and claim credit, log into mededtalks.com and search Lipid Legends Season 2, or click the link in the notes section of this podcast. Now, here's your host, Dr. Underberg.
Hello, and welcome to the Lipid Legends podcast series. This continuing education series is supported by educational funding provided by Amgen, Arrowhead Pharmaceuticals, and Novartis Pharmaceuticals Corporation. I'm your host today, Dr. James Underberg. I'm a clinical assistant professor of medicine at the NYU School of Medicine and the NYU Center for the Prevention of Cardiovascular Disease. I'm the director of the Bellevue Hospital Lipid Clinic in New York City and past president of the National Lipid Association and the American Board of Clinical Lipidology. And today I'm lucky enough to be joined by my colleague and friend, Dr. Pam Taub, who is a professor of medicine and director of preventive cardiology, an endowed chair and founding director of the Step Family Foundation Cardiovascular Rehabilitation and Wellness Center at UC San Diego School of Medicine in La Jolla, California. Dr. Taub, thanks so much for joining me today.
My pleasure, Jamie.
So we're friends. We're going to call each other by our first names, Pam, and I like Jamie. So I just want to move forward and say that in this Lipid Legends podcast series, I have the pleasure and the unique opportunity to interview expert physicians and researchers on topics that are of current importance in the field of lipidology. And today, what we'll be discussing and focusing on is all aspects of lowering LDL cholesterol, or LDL-C, for cardiovascular health and the reduction of ASCVD risk. We'll also try to get to know Dr. Taub a little bit better. So, Pam, to start off, can you tell us a little bit about your background, how you ended up in the field of first cardiologist, as you are a cardiologist, but then after that, the field of lipidology? I always love hearing about people's journey in this process.
Well, I've always been interested in lifestyle and how to maximize lifestyle strategies, whether it's diet optimization, physical activity. And when I was in medical school, I got zero education about these things. And so I learned a lot of this on my own through attending lectures, reading, talking to experts in the field. And so in my residency and fellowship training, I soaked in as much knowledge about basically preventive cardiology, lipidology. And when I finished my cardiology fellowship in 2010, the field of preventive cardiology was really at its infancy. And I say preventive cardiology because it encompasses lipidology. I mean, lipidology is so fundamental to what we do in preventive cardiology. And so I really wanted to start the field. At UC San Diego, we didn't have any preventive cardiology. People would laugh at me and they said, "What is preventive cardiology? You just give everybody a statin." Or what is cardiac rehabilitation? Just go tell people to walk and go on the treadmill. And so at that time, it was really not thought of as a bona fide subspecialty as it is today. And there was a lot of tools that we didn't have available to us. So my interest was really driven by a passion for lifestyle medicine and also evidence-based pharmacotherapies, but it was driven by a passion to prevent disease because as a cardiology fellow, I hated seeing these patients with end-stage disease, and we would throw so much at them at the end of their life. We would replace their valves, we would do coronary bypass surgery, and then multiple stents after the bypass surgery, and then we would put in an AICD because their heart function was low, and it was just very unsatisfying to see that end-stage disease when we can do so much up front. So clinically, I wanted to see that change. And I also wanted to see it from a research perspective and also implementation of creating centers of prevention and really fostering cardiac rehabilitation. And so that really drove me to prevention and lipidology.
That's great. I love everyone's story. They're all a little different. Everyone's so passionate about what they do. We're very lucky to have colleagues and peers that care so much about this. You know, your CV is rather extensive. I have a little trouble. I wanted to ask you, what career achievement are you most proud of so many honors, awards, and accolades?
I think I'm proud at the local level at UC San Diego in establishing preventive cardiology and also one of the largest cardiac rehab and wellness centers in the world. And as I said, when I finished my fellowship in 2010, it didn't exist. And I was also given a unique opportunity to be able to create this. And a lot of it was because of philanthropy, and a donor believed in this vision of prevention. And at that time, we were building our large billion-dollar addition to our smaller hospital. And there was some space on the first floor that happened to be available right at the main entrance. And I was entrusted with this task of designing, creating a center, and doing every aspect of building this. So I'm very proud of that at a local level. But at an international level, I'm very proud of the research that I've done that has advanced the field in lifestyle medicine. I've done a lot of work on time-restricted eating, which is a type of fasting which improves cardiometabolic health. I've served on guideline committees and have helped really reshape how we think about lipid lowering. And so all of these things I'm very proud of.
Great. So that segues perfectly into our first area of discussion. And that's, you know, the concept of LDL cholesterol lowering. And in particular, why is early and sustained LDL cholesterol lowering so important for reducing cardiovascular risk?
Well, I think that we are focused on secondary prevention, and that's great. That is an area that we need a lot of emphasis on. But when we focus on more high-risk primary prevention, that's when we really need to think about cumulative exposure to a toxin. So LDL is a toxin, just like tobacco, just like other materials that can be very harmful to us. I think of sugar, too much sugar, also as a toxin for our body. And so the longer you're exposed to this toxin, the more damage it does to your arteries. And so we know, for instance, with patients that have familial hypercholesterolemia, that cumulative exposure since birth exerts an influence in terms of when they manifest disease, which is much earlier on, sometimes in their 20s or 30s. And in general, in the population, we are starting to see myocardial infarctions and stroke happen at a much younger age because of this cumulative exposure to this toxin. So I think the earlier we start, both with lifestyle strategies, but also with appropriate pharmacotherapy, we're doing a better job at reducing that toxin exposure.
Yeah, it's interesting. We had a conversation just today in our lipid clinic here at Bellevue around the idea of not what is the cholesterol today, but for how long has this patient been exposed to high cholesterol, and that cumulative exposure that you're referring to. And all too often, I think we think about what's happening today and not what has preceded all of that to get the patient to where they are. So with this in mind, how do current guidelines recommend assessing cardiovascular risk, particularly in high and very high risk patients? And what LDL cholesterol targets or goals should clinicians be aiming for in these patients? I'm curious, where are we right now in regards to assessment?
Well, I think we've come a long way. And I think your perspective as president of the NLA, you have also seen over your career this incredible shift to lower and lower and lower. And that's something that I've been pleased with in my career, seeing us go from an LDL target in the hundreds for our very high-risk patients now to even less than 40 per the ESC guidelines. So it's been really rewarding to see that shift in how aggressive we're getting. And it's also very gratifying to see that as a medical community, we're all appreciating how important LDL is to the pathogenesis of atherosclerotic cardiovascular disease. And so what I like to see is the guidelines that are coming out next year for AHA, ACC really emphasize this lower is better LDL goal. And it's interesting. When I was a cardiology fellow, Dr. Braunwald gave grand rounds at UC San Diego, and I had an opportunity to sit with him at dinner, and we were talking about LDL. And I remember he said to me, our LDL should be really low in the 30s to 40s. And he said that's eventually where guidelines were going to go. And back in 2009, I thought he was really being dramatic, but what he said is true. That's where we have gone over time. Is the evidence has really pointed us to getting the LDL as low as we can.
So I'm curious, you live in a world of cardiologists, and how many of your colleagues do you think are driving LDL cholesterol levels down below 55 milligrams per deciliter right now in patients with ASCVD? I'm just curious.
I think in general, the preventive cardiologists, we're a subset. We all subscribe to this mantra of lower is better for as long as you can. But in the general cardiology community, I think the uptake is a little bit slower. And I think it's because people are stuck on statin monotherapy. They're not really utilizing a lot of the newer non-statin agents. And they really haven't caught on to this concept of combination therapy, which is what I know you do. I know that I do in my clinical practice. And that's what it really takes to get LDL to these very low levels.
So once again, you led perfectly into our next area of conversation, which is you mentioned statins as first-line therapy. For many people, that seems to be the beginning and the end, unfortunately. But we now have this incredible armamentarium of non-statin agents available to us that I think for both of us weren't even around when we did our training. So can you take us through what the main non-statin available options are today, right now, that one could use?
Yeah, there's a multitude of options. So the first one was ezetimibe, which really works on intestinal absorption of cholesterol and decreases intestinal absorption of what we consume from our diet, and that reduces the LDL about 15%. I think the real revolution came with the PCSK9 inhibitors that lower LDL cholesterol 50 to 60%, and now we have two different types of ways of delivering PCSK9 inhibition. One is through monoclonal antibodies like alirocumab and evolocumab, and another is through a small interfering RNA technology called inclisiran. So the PCSK9 inhibitors, I think, have been revolutionary. We also have bempedoic acid, which is a non-statin agent that's very useful for people that need additional LDL lowering, maybe have some partial or complete statin intolerance. And then we have so many new therapies in development, including gene editing for patients who have familial syndromes. So a lot we can offer our patients.
Yeah, it's always very exciting when you can offer options to people, either because they need additional LDL lowering or maybe they can't take statins at optimal dosing or schedules that we would want them to be on. But even with all of that in our back pocket, so to speak, we're also lucky. This is such an exciting field right now because potentially new therapeutic options seem to be exploding every week on the horizon, so to speak, no pun intended. We've got a whole bunch of drugs in the development process for lipoprotein A, which we're not going to talk about today. But I did want to have you address, if you could, obicetrapib, which is a new CETP inhibitor in development, and lirodalsipib, which is another PCSK9 inhibitor that is a monthly self-injection. I wonder if you could just give us a brief overview of these two agents.
Yeah, obicetrapib is a very interesting molecule. Even though it's considered a CETP inhibitor, it has a lot of benefits. It lowers ApoB, it even lowers lipoprotein A, in addition to raising HDL cholesterol. And so there is a phase 3 outcome study that's ongoing called the PREVAIL study. And I think based on what we're seeing in some of the earlier data with the extent of atherogenic lipid lowering, it's very likely to be a positive study. So it's a novel agent, and it would be the first CETP inhibitor that we would have on the market. I know that there's a lot of controversy about some of the older generation of CETP inhibitors, but this is a very unique molecule and it's very promising. Lirodelsipib is another novel molecule. It's a PCSK9 binding fusion protein. It's a monthly injection, and significant LDL reductions were seen, close to 60% with this molecule. So that's exciting. But the other exciting areas are we have oral PCSK9 inhibitors, and some of that data has been presented. And that's a very nice option to have an oral agent. And we will have one on the market. And then the other exciting area is really taking these PCSK9 inhibitors that are approved for secondary prevention and taking it to patients with high-risk primary prevention. And that's going to be something that we can look forward to, because the Vesalius study is going to be presented next week at the American Heart Association meeting. And we've already seen the top-line results that in patients who have evidence of atherosclerotic cardiovascular disease but have not had a myocardial infarction and stroke, that there is a benefit in terms of cardiovascular outcomes. So that's exciting. And then we also have the Victorian 1 Prevent study, which is a study looking at high-risk primary prevention patients, again, that haven't had an event but have high-risk features like type 2 diabetes, elevated coronary calcium score, and we're going to look at what is the impact of inclisiran in that patient population. So to me, that's the most exciting, is taking these agents that we know work in secondary prevention and looking at them upstream.
Right. And I always remind people also that the bempedoic acid outcome trial included a high-risk primary prevention population also. So we haven't had primary prevention data from pharmacologic intervention since the statins until these recent agents and their data. So it's very exciting for those of us who see high-risk primary prevention patients, because often their family members have someone who's had an event and they're terrified and they want to know what they can do. And so it's great we have all these new potential and even currently available tools to help them with. So with all these options, still, you and I both know the data that many high-risk patients fail to achieve their desired or optimal LDL cholesterol levels. And sometimes intensifying therapy can be difficult. In your practice, I'm curious, just from your own clinical experience, what are the barriers that you see and how are you addressing them?
Well, I think that a lot of patients do truly have statin intolerance, either partial or full. And 20 years ago, we didn't think it was real, and we would dismiss these patients. But now we know that it's a real entity, and it's really acknowledging that there are many patients that cannot tolerate statins and giving them other options. But it's also figuring out for that particular patient, what are the issues? For some people, it can be cost. For some people, it's an adherence issue, and inclisiran is a great tool for people that can't take medications regularly. We can give it to them every 6 months. So that's, I think, a big breakthrough. But I also think it's about figuring out the whole picture, because sometimes the reason patients aren't focused on lipid lowering is because they have other issues such as obesity and type 2 diabetes. And this is where we have to take a holistic approach and, treating that obesity and getting their weight down, whether it's pharmacotherapy or lifestyle, that can impact lipids. And so we have to see where the patient is at in terms of the number of medications they're taking, slowly escalate. Sometimes it's hard to get a patient to take many medications at once. It's sometimes about, adding one thing at a time and then seeing what the result is. But it's important that we are constantly rechecking and reassessing. And with our secondary prevention patients that are very high risk, doing a combination strategy up front is very important at the time of discharge. And studies have shown that when you do it right after their hospitalization, they're more likely to adhere.
More likely to adhere. And there's even some post hoc data suggesting more likely to do better from an outcome perspective. It's not randomized control, but I was going to ask you this concept of lower is better for longer, meaning sooner. What's going on at your institution? Are you starting PCSK9 inhibitors in the hospital now at discharge?
We're not doing that yet, but we are doing it as quickly as possible because most people after an ACS admission get a follow-up visit within a week or two of discharge. And at that time, we're evaluating very carefully what their lipid-lowering regimen is and then starting an agent. And the key is after you start something is to have that subsequent follow-up. Make sure you're getting to the level that you need to be. And we're really trying to do that upfront combination strategy. There was a recent paper from the Sweetheart Registry, which I think you were referring to, which is that combination of statin and ezetimibe upfront is very efficacious in reducing LDL, but also events. And the other insight from that study is sometimes you want to throw, 80 of atorvastatin or 40 of rosuvastatin at that patient that has had an MI. But the problem is you throw that at them and they have side effects and they just don't want to adhere. And so you can be a little creative and say, okay, I'm going to do 20 or 40 of atorva and add 10 of Zetia, and you're still going to get the lipids down lower, as low as you would with maximum intensity. But because you've done a lower intensity statin, their side effect profile is much more tolerable. So I think we're getting more creative in our approaches because I remember when I was a cardiology fellow, it was everybody got discharged with 80 of atorva or 40 of Rasuva. That was the mantra. And 6 months later, most of them weren't taking it.
How often do you actually see these patients back to follow and monitor their cholesterol levels, either after you first initiate or change a medicine, and then once you have them stabilized? I'm curious.
So I try to see people after that first discharge appointment within 4 to 6 weeks and get a repeat lipid panel because they're so, especially if it was a recent ACS event, they're very engaged. Their families are engaged. And so I think that's kind of a really important window of opportunity to get them on the right regimen that they can tolerate.
Both you and I started doing this before preventive cardiovascular medicine was a thing. I call it that because I always say you don't even need to be a cardiologist to prevent heart disease. And we've been lucky enough to practice in settings where we have a lot of support from our institutions and colleagues. What's your advice to young people? I'm sure you serve as a mentor, an advisor, and a listening ear to your younger trainees. But what would your advice be to someone who is interested in these fields of either preventive cardiology, lipidology, et cetera?
Well, I think it's a really exciting field, both from a research perspective and from a clinical perspective. I still think it's a very young field. I still think that there are so many new therapies that are going to be coming out. I think there's going to be a lot of research into important pathophysiology of what's driving disease. And I think also this integration of the cardio, the kidney, the metabolic, the liver, I think that's really exciting. And so I think for young people that are really interested in making a dent in prevention of disease, it's a very exciting field. And I also would encourage them to think about unmet clinical needs right now and come up with a research project or an implementation science project to make our field even better.
So I just want to try to summarize briefly this incredible conversation that we've had today. First, we heard your story about how you got to where you are. And I always love hearing that part because everyone always has these great stories. We talked a bit about why LDL lowering is so important and why we need to think about not just what is the LDL today, but how long has it been elevated for and how aggressive we need to be based on that, and that lower is better for longer. We talked about current guidance with 50% reduction, less than 70 and 55, and even lower 40 for the European goals, and that we have new guidance coming out probably in the springtime that we may need to reassess how we think about these patients again. It'll be a busy time for us, I think. We went through the currently available non-statin therapies, ezetimibe, PCSK9 monoclonals, evolocumab and alirocumab, inclisiran and siRNA, and bempedoic acid, an ATP citrate lyase inhibitor. And then some of the exciting new things that are in development, CETP inhibitor, obicetrapib, couple of different new technologies for PCSK9 inhibition, novel mechanisms, increased duration between injections or even oral agents, and then some of the barriers that we face along the way. So I'd like to just throw it back to you, Pam, just for some final thoughts about this and where we're going and how you see yourself in this space going forward. I always love to hear about what our future thoughts are.
Well, I think we're in an exciting area in prevention, cardiometabolic disease, lipidology, but we still have a lot of work to do. I mean, if you look at the recent AHA statistics on the incidence of cardiovascular death, it actually went up. And so there is a lot of work to be done. And I think one of the things that we have to really focus on is access. How do we get these incredible therapies to our patients? And that also is cost. And some of the newer agents that I mentioned, the cost of goods or the cost of production is much lower. And so I am very hopeful that a lot of these medications will be more affordable. But we have so much to do, Jamie.
Well, it's great that we're still excited about it and that we can have these wonderful conversations and share some of the energy and excitement for the field, because I think the more people hear about it, the more they're likely to engage and be excited about it. So I want to conclude by thanking you, Pam, for this amazing discussion, and thanks to our audience for listening. Please remember to take the post-test question at the end and do the evaluation, please, to receive the CME credit. We want to know your thoughts. Also, please tune in for additional episodes within this series. In our next episode, I'll be speaking with Dr. Howard Weintraub about the role of lipoprotein A and the potential impacts of emerging therapies. So thank you very much for your time and attention, and thank you, Pam, for being our guest today.
Thanks again for listening to MedEd Talks Cardiology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends Season 2.